everybody, and welcome to ABA Inside Track, the podcast that's like reading in your car, but safer. I'm your host, Robert Perry Cruz, and with me are my fabulous co-hosts.
Hey, Rob. It's Diana.
Hey.
Hey, it's Jackie.
Hey, y'all.
Hey.
And we are joined with an extra special guest co-host live via the internet, Dr. Sandy Jin. Hi, Sandy.
Hi. Hello, everybody.
Hi, Sandy. Thanks for joining us.
Thank you. Thank you for inviting me.
Absolutely.
I stalked her.
You're so good at that, Jackie.
Dear Sandy, hi, how are you? I am fine.
How are you today? How are you today?
What are you doing today, Sandy?
How are you today?
How about today? Are you
That
busy
was very
today?
cute. She has been stalking me for about 3 weeks.
It's like my favorite thing to do.
It's your talent.
I know. I love internet stalking people.
It is good. It is good to do sometimes.
LinkedIn, Twitter, everywhere I can find you.
Well, Jackie stalked and asked Sandy to be on the show because we are going to be talking about sleep. Sleep. And Sandy wrote an excellent article about sleep, and we said, hey, we should probably have the person who wrote this article talk about their article, and we don't have to do it. Yay.
Bait and switch.
Sleep is my favorite topic right now, so I'm pretty jazzed that we're talking about it.
Is that because
I'm not getting any.
you just fantasize about it?
Yep. I think about sleep during the day. I think about sleep during the night when I'm not sleeping.
I think that's the most amazing thing about maternity leave. It's like you have all this time. You could do whatever you want except sleep.
Right.
That's the only thing you want to do and the only thing that you can't
Right.
do. Like you can do anything you want to while you stare at this baby.
Except for
Don't
sleep.
take your eyes off her.
Because and I'm not even on maternity leave anymore. I'm working, but I'm
still going.
Sleep. It's
Guys, I just suddenly realized everyone must think this is some sort of a maternity leave sleeping podcast, but it is in fact actually a podcast about behavior analytic research. No, that's my fault. I'm the host. I should tell everyone what they're listening to a lot earlier than I do. So this is ABA Inside Track, the podcast about behavior analytic research as opposed to about maternity leave sleep habits. But we may find some common ground in our discussion today. So we're going to be talking about some specific articles. But before we do that, let's get to know our super special guest co-host a little more. So, Sandy, tell the audience about you.
I am passionate about research on the assessment and treatment of sleep problems, and I have been working on research and clinical cases related to sleep for, I would say, approximately 8 years now. And again, this all started back when I was a doctoral student at Western New England University under the mentorship of Dr. Gregory Hanley. And he was very interested in identifying some of the variables that cause sleep problems in young children diagnosed with autism. And we essentially wanted to apply the functional assessment methodology to the sleep literature and design interventions that are not only efficacious, but consumer friendly. So
sounds cool.
That was a really good summary.
It was.
And where are you now?
I am currently an adjunct professor at California State University, Northridge, and the transition just literally occurred about 5 months ago. So now I'm back home in Southern California.
Congrats.
Sweating.
Thank you. I'm very excited.
California sounds really nice. After we had the longest drawn out transition to spring ever this year here in Massachusetts, and it just ended this past week. It's finally spring in Massachusetts. It took this whole time. So California sounds really nice.
Thank you.
Yeah.
I do miss New England, though.
Yeah?
Yeah.
Well, we miss you.
I miss you.
Thank you.
So let's get into some article discussion. So the main article we'll be talking about will be Sandy's article, which... Do you remember the title off the top of your head, Sandy? Or I can read it. I know it's been a little while since you published.
Of course. The title of the article is An Individualized and Comprehensive Approach to Treating Sleep Problems in Young Children.
Very good. Good. You pass. Hooray. And
Yay!
that was a Journal of Applied Behavior Analysis back in 2013. And we also have a second article you'd recommended, which we might not talk too much about, but you do mention in your article, The Bedtime Pass, An Approach to Bedtime Crying and Leaving the Room by Friman, Hoff, Schnoes, Freeman, Woods, and Blum from the Archive of Pediatric Adolescent Medicine.
Yes, lots of co-authors on that article, and I do have to say that it is one of my favorite articles in the sleep literature.
Absolutely. I hope we get to talk about it.
Yeah.
But we'll save it. Because it's a quick one. Mm-hmm. So we can probably talk about it quickly at the end.
So let's start by getting into, you talked a little in your introduction about why you and your co-authors wanted to look at sleep. So your general purpose was sort of how can we use behavior analytic literature to look at sleep problems in individuals, specifically individuals with disabilities. So how did you kind of start thinking about the process as a whole? If you can remember that far back.
Well, again, we were referred with clients who, young children who experience sleep difficulties, and we looked at some of the existing interventions available for sleep problems and looked at some of the limitations associated with existing interventions and realized that functional assessment process hasn't really been applied thoroughly in this area. Mm-hmm. So that's what really motivated this whole process. But, we can certainly get into the specifics of the various limitations associated with previous research. Is that what you kind of wanted to talk about?
Yeah, I think sleep's one of those things, and you mentioned in the introduction that everybody needs, so when you can't sleep well or your kids can't sleep well, it's a problem. And I think you had some really high percentages of children with sleep problems that sort of go not quite unheeded by pediatricians, but sort of get told, oh, don't worry about it, they'll grow out of it, kind of.
Yeah, certainly. So yes, sleep problems in young children is certainly a commonly reported child-rearing difficulty, and parents frequently complain about these problems to pediatricians. And what's also interesting, it's one of the primary reasons for prescribing psychotropic medications to young children. So if you look at the prevalence estimates from various studies, they're actually quite high. Sleep problems affect approximately 35 to 50% of typically developing children and up to approximately 75% of children diagnosed with autism. So this is certainly something that parents struggle to handle.
When you say sleep problems, is that primarily delayed onset of sleep at nighttime and then waking up?
Right. So by sleep problems, we mean things like sleep phase shifts, delayed sleep onset, problem behaviors that interfere with sleep onset,
like
waking
crying
up in the middle of the night. Yeah, certainly crying, calling out, getting out of bed, and more severe forms of problem behaviors as well, like aggression and self-injury. But not only that, sleep problems also include waking up frequently in the middle of the night for an extended period of time, or waking up too early and not being able to fall back asleep.
It's not really gone into in a lot of depth in your article, Sandy, but have you looked at what's the prevalence of success that parents who medicate their children to solve sleep problems actually have? Because I know just in talking to families, I know lots of families who, they're on melatonin, they're on Benadryl, and no one ever's like, and it's working great and everything's perfect and all our problems are solved. I mean, is that just my anecdote, or is medication not that successful?
When parents begin to seek treatment options, they may certainly attempt to handle or solve the problem on their own prior to visiting their pediatricians. But when they do visit their pediatricians, and a lot of pediatricians do certainly recommend behavioral interventions, they may also recommend some type of pharmacological interventions. And based on, certain review of visitation records, I believe as many as 81% of children's visits result in some type of pharmacological recommendation, although, that number certainly could have changed since 2007. Mm-hmm. Unfortunately, there are no prescribing guidelines right now related to the handling of sleep problems, and no drug approved by the FDA. And there are very limited research on the efficacy, tolerability, as well as acceptability of pharmacological intervention. So, parents and pediatricians are certainly using a lot of pharmacological interventions, but we just don't know a whole lot about their efficacy as well as social acceptability as of now.
Okay.
Yeah. I thought it was shocking in your article when it said that general pediatricians only give about 5 hours of training total on sleep.
Right, and that's certainly based on a number that has been reported in a study. But, more importantly, some of them may recommend to parents that, their children will outgrow these problems. And I think that, some of these suggestions from pediatricians are certainly very helpful, but we also have to kind of identify areas in which, as a field, can assist with pediatricians when they are kind of recommending different treatment options to parents, because, identifying efficacious interventions to improve the health and development of young children is certainly a common goal among pediatricians, behavior analysts, and other childcare professionals. And I do think that as we sort of disseminate our behavioral interventions more effectively to pediatricians, perhaps we can place more effective tools in the hands of doctors as they're attempting to help parents and caregivers to handle these problems.
Diana, to put that number in perspective, I took an undergraduate class on the science of sleep, so I now have more training than your average pediatrician in sleep. So, parents, call me. And I read this article too, so I'm like way ahead of the game.
That's right.
That's awesome.
You can draw yourself a little diploma and hang it on the wall.
That's right. I actually have a real diploma based on that class. I got some credits towards my...
That seems crazy though, because as I'm just going through this like whole new world of pediatrician, like the only thing I really ask her is, what should I be feeding this tiny human, and how should they be sleeping? Like, those are really the only two things that I ask every single time I go. Mm-hmm. So shouldn't those be the two things that the pediatricians know most about?
Right, and I think that they certainly do know a lot about eating, how sleep is regulated and how sleep is modulated and sleep architecture. And when it comes down to preventative strategies for sleep problems, I think that some of them certainly have great recommendations. But when problems exacerbate to different types of interfering behavior that could lead to delayed sleep onset and night awakenings, I think that, again, pediatricians certainly do recommend behavioral interventions, but the type of behavioral interventions that they do recommend to families and caregivers may not be the most effective forms of intervention. And I think that we just certainly have to place those tools in the hands of pediatricians, or perhaps, as a field when we're assisting with different cases.
I think sleep suffers from some of the same type of misperceptions as other more complex human behavior, in that we don't always think about it as behavior that can be modified through behavioral intervention, right? If you go to the pediatrician as a new parent and your baby is crying at night, well, then they're just going to tell you that the baby will grow out of it. And some babies will grow out of it and some won't. And then if your baby doesn't grow out of it, I think parents kind of just label their baby as, my baby's a bad sleeper, right? And at that point, they're just anticipating continued problems with sleep with their baby, or they, sort of allow themselves to continue some of those strategies that are maladaptive.
Right.
Because now they have a bad sleeper baby, and that's just going to continue. Versus thinking of, sleep is just behavior, and we can make changes to it by modifying the consequences just like anything else.
Yeah, that's a fantastic point. And I think that as a field, we certainly view these types of problems as skill deficits. And that's a very hopeful approach, because that means that we can address these problems by understanding the controlling variables and by understanding what skill sets would need to be taught. And again, one of the misconceptions about how our field sort of treat problem behavior is that we may certainly, look at the ontogenetic variables or some sort of environmental changes, when we do care about, phylogenetic variables too, and some of the, biological influences of sleep.
So, Sandy, getting into sort of the planning for the article or the thinking of the article, I know when I read it, kudos. It's one of those articles you read and you're like, oh yeah, no, this makes perfect sense. That's how behavior is. You do a functional analysis, you look at variables. It's so straightforward. in terms of the planning of how to conceptualize the idea of sleep as a behavior that there's motivation, you can have abolishing operations. Was it something that you kind of just sat down, thought of, and it just, yeah, that makes perfect sense? Or was there sort of a weird roundabout way you had to go to sort of figure out how you're going to tackle this problem?
A lot of it was actually based on, teaching from Dr. Greg Henley. I thought that, he had a great conceptualization of the behavior, and he also sort of had a lot of the aspects of the sleep assessment and treatment tool ready. So that certainly helped us to kind of continue with the study. But I think that the conceptualization was also assisted by this fantastic review article by Blum. I believe the article was published in the Journal of Applied Behavior Analysis, and it really inspired behavior analysts as well as practitioners to sort of look at sleep through the lens of the contingency.
Greg couldn't come up with an acronym that spelled sleep for his sleep assessment. It's the SATT, the Sleep Assessment Treatment Tool.
Sleep Assessment and Treatment Tool, yeah.
Yeah, he couldn't have done
the sleep learning
education and informational profile. So it's SLEEEP, but it's spelled sleep. Okay, you check in with him on that. Maybe change the name.
Yeah.
Yeah, we gotta talk to him about that. You gotta market that guy. You gotta market that a little more. We'll workshop it.
All right.
I like the name of the tool because it's just very straightforward. It is really just a tool for sleep assessment and treatment.
You're right. It describes exactly what it does, and it is a very, very useful tool. I agree.
So could you describe the idea of sleep as a behavior?
Well, falling asleep is a behavior, and I think that that's where we can get started. When we look at falling asleep as an operant behavior, we could begin to understand it by looking at antecedent conditions like dischronous stimulus, as well as establishing operation that occasion falling asleep and the reinforcer for falling asleep. So in order to get sleep to occur, we attempt to enhance contingencies that maintain falling asleep as a behavior or strengthen falling asleep as a behavior. But we also have to sort of look at problem behaviors that interfere with sleep onset. That's the other aspect of understanding sleep as a phenomenon. Because if you're not sleeping, you're inevitably engaging in some other, and there are controlling variables for those behaviors as well. So, for example, a child's cry or calling out might be maintained by access to attention and access to tangibles or escape from dark bedtime environment. Manipulating those contingencies and weakening these variables that strengthen interfering behavior could essentially help us to increase the likelihood that a child will sleep throughout the night. We also look at, like I said previously, not only ontogenetic variables that maintain falling asleep, but we also look at evolutionary history of sleep, as well as past and present experiences in one's sleeping environment. And I think that those variables, in addition to certain cultural practices, could certainly help us to design more effective as well as socially acceptable interventions for sleep problems.
One term that I learned in the course of learning about sleep was sleep hygiene.
Oh my God, I've been trying to think of that word for like 3 weeks now.
Oh, yeah?
And I've been waiting for this to be like, what was it? I was like, sleep schedule, sleep something, sleep hygiene.
It's sleep hygiene, which is kind of a funny term.
I love that. I've been trying to bring it up to my daycare workers.
Oh, yeah?
You want to wash your sheets
every
night.
Sheets every night.
Brush your bed.
Right.
Is that a term that's still in use?
Yeah, and I think that it's a term that's certainly more popular for the medical professionals, but it really doesn't mean anything other than a specific set of practices that lead to healthy sleep.
Like dental hygiene leads to healthy teeth.
Right, exactly.
Okay, gotcha. So good rules of sleep hygiene are don't be too active before bed.
Sure.
Don't do something as you're falling asleep that's not going to be present in the middle of the night.
Yes.
To wake you up, right?
So sleep dependencies that are consistently available throughout the night is certainly an important aspect of maintaining good sleep hygiene. An adequate amount of sleep that is developmentally appropriate. So not sleep for too short period of time, but also ensuring that your sleep doesn't exceed a developmentally appropriate amount.
I have a friend who always has to fall asleep now to the TV because when she was little, her mom would have the TV on, and now literally she cannot sleep in her bedroom. She sleeps in the living room every single night.
Oh, that's
and
horrible.
Sleeps because she has to have the TV on.
Yeah.
Jeez. So, but does she keep it on all night long?
Yeah.
Oh, wow.
Oh, wow.
And because if she wakes up and the TV's off, she has to turn it on.
Right.
So she keeps it on all night.
Oh, goodness.
She should fix that. Right?
I know. I tell her this is the worst. When she comes over, they're like, we made up a bed for her. I'm like, she's not going to sleep on a bed.
I feel like as an adult, the treatment is get over yourself, turn off the TV. Looks like you're going to be tired tomorrow. You'll pass out the next night. Don't worry.
That's funny.
Thanks, Dr. Rob.
And that's what you do for kids, I'm assuming, too, right, Sandy? You're just like, kids, suck it up. Wake up on time. You'll be tired, right? Is that easy? That's the article? I think I read it. I think that's what it said, right? Or was it more complicated?
I can't remember, actually.
So my thing, we'll assume, was right. I was totally right.
Sandy, I'm really interested for you to tell us how you did this. Like, what did you do? Tell us about your procedures and tell us about how long it took you. And, like, did you go to people's houses and, like, spend the night and sleep on floors? And
Oh, goodness, yeah.
Give us the dirty.
We recruited families from the local community, and there were a lot of families with children who experienced sleep problems. So it just all sort of started there. And once they, consented to the procedures, we essentially began.
That's good. I'm glad you got consent first. You weren't just showing up at people's houses.
We snuck under children's beds and used that data.
We Monsters Inked them.
Just use a simple portal through the door to another dimension.
Yeah. So obtaining consent was certainly an important aspect of the study because we only instructed parents to collect data via parental diary. We also placed camcorder within the bedroom to track their children's sleep. So it's very important that they were aware of that.
Right. You might be going to jail.
That's where we all started. And surprisingly, we thought that families would be reluctant about having a camcorder placed within their bedroom. But surprisingly, all the families were essentially said, yes, we're ready to, treat sleep problems because they've attempted so many different strategies in the past and have experienced failures. So I think that they're just kind of ready to fix the problem.
They were too tired to say no.
Yeah.
Yeah.
And many of them have been getting poor sleep for a very, very long time because of their kids' sleep problems.
That's the thing is when it's a newborn baby, it's like, yeah, you're tired, but
this too shall pass.
You expect it to pass, and then you meet families who have been doing what is essentially like caring for a newborn baby, but for 7, 8, 9 years.
No.
And then you could just only imagine the level of sleep deprivation that they're working under. And stress,
Right.
It stresses out your body so much
Right.
when you lack sleep. So I really feel for parents when they're in this situation. And no wonder they were like, yes, please, come in. Put up whatever you want.
How many camcorders would you like? We'll put one in our bedroom, too, just anywhere.
No. Ma'am, that's fine.
Yeah, they were certainly motivated to, begin this study.
Yeah, it's a serious problem. And it's one that's so hard for us to treat because we're not there at night.
Right. And for this particular type of problem behavior, I really do think that the parents have to be heavily involved because they're the ones who are at home and they have to implement these strategies and they understand, the problem behavior, I think, to some extent, or certain aspects of the problem behavior more than we do.
Sandy, could you talk about I know you talked about kind of the setup of how you're going to collect the data with the diary and the camcorders. Could you talk a little bit about the initial sort of interview and assessment process that you went through? Because I know it was both straightforward, but also had a lot of great components of social validity and using the parents to be a part of the overall planning.
We first collected baseline data, and we certainly instructed parents to fill out sleep diaries and record things like when they bid the child good night and when the child fell asleep, how many times they woke up and what happened. And I think that some of the things that I really appreciated about the sleep diary is that even though it is often considered as subjective, it's providing us with a lot of, qualitative information that we may not get with the video. Obviously, we also placed an infrared nighttime video there to ensure that what the parents were reporting were accurate, and we also were able to more precisely observe the problem behaviors or interfering behaviors at bedtime. So following this baseline phase, we did administer an open-ended clinical interview with the sleep assessment and treatment tool that you mentioned. And, the interview period lasted anywhere between 1 to a little bit more hours. And we essentially took all the information that we already knew from the data that we collected, but also what the parents thought about regarding their children's sleep problems. So during the interview, we're able to identify their sleep goals, what they wanted to achieve, and whether those goals were appropriate to the case. We're also able to come up with interventions that are more feasible for them and that are more socially acceptable for the family members. And I think that some of the great features of the assessment tool is that it really guides the clinical interview by asking things like, what is the sleep dependency and how do we address those inappropriate sleep dependencies and introduce healthy sleep dependencies? What is the sleep schedule? And can we do anything to change the sleep schedule if, sleep phase is occurring at inappropriate times? What is the nighttime routine? Are there anything we can change with respect to the routine? And what are the types of interfering behaviors that could happen at the beginning of the night, in the middle of the night, or really early in the morning when they wake up? What are the potential or putative reinforcers that could be maintaining these reinforcers? And I think that the interview is not only sort of assessing the problem, but also giving families and parents an opportunity to really understand sleep problems from a more sort of behavior analytic perspective, and getting them to brainstorm and getting them to come up with some of the intervention strategies that could work within their family environment.
I love that. I think that's helpful. Instead of just going in and being like, you're going to do this, I rule your house. Yeah.
Right. And I really do think that, part of what sets us apart from, some of the pediatricians' recommendation is that, things like planned ignoring or graduated extinction are recommended often by physicians, but we don't really know the extent to which parents could comply with these treatments, right? So when they're expected to implement extinction for attention-maintained problem behavior, some of the parents may have a really difficult time hearing their kids cry. And as I was scoring some of the videos, I was having a really difficult time hearing crying and calling out. So I
you put it on mute.
I can't really do that as a point. But I think that, for parents, it's certainly difficult to tolerate. So I think that for these families, we certainly have to look at more feasible alternatives, and we can certainly offer treatment options that's other than the typically recommended quote unquote graduated extinction, right?
Yeah, because it's really easy to say to do something like graduated extinction or
right,
time-based visiting, but it is hard when your child's crying. To wait.
And I think that, for some families, you just have to figure out what works for them. And for some families, I would say, parents don't really want to check on their kids at regular intervals or increasing intervals. They find that to be a little bit effortful, whereas for other families, they do want more opportunities to connect with their kids. So, something like time-based visiting would work for them. And surprisingly, for some families, extinction might be a more preferred strategy, especially when they find it to be a little bit more, I would say, easier to implement at times because they don't have to check their intervals and they don't have to potentially wait longer and longer periods of time prior to attending. And many parents prefer bedtime pass because it certainly gives children, a voice in all of this.
Hey everyone, sorry to interrupt the episode, but I wanted to make sure if you're applying for continuing education credits with ABA Inside Track, you have one of our secret code words, because you will need this and another that you'll hear later in the episode when you apply for your CEs, just to make sure that you listened to the whole enchilada. And the first of our code words is NEMO, N-E-M-O. You might wonder what that has to do with sleep. Just Google Little Nemo. But for CE requirements, you just need NEMO. All right, back to the show. So I think some of the treatments you were just talking about, Sandy, are pretty self-explanatory in terms of if it's some sort of attention maintained, I'm not going to bed, extinction's going to be, don't go in, don't go in, you know. The mean parents like that one. I'm going to ignore this crying kid for as long as it takes. The time-based visits, visiting on a set schedule. But the bedtime pass, and I know that's one of the other articles you recommended. Would you mind talking a little bit about the bedtime pass itself and what that procedure entails?
I love the procedure, and I love recommending it to parents. But essentially, bedtime pass follows the logic of a differential reinforcement of alternative behavior procedure. When we recommend it to parents, we typically say that you can create your own pass that is somewhat attractive to your child. Give your child one or more bedtime passes at night to be used as needed after bidding goodnight, and they could be exchanged for different putative reinforcers that maintain sleep interfering behavior. So, for example, if the child's cry or call out is maintained by parental attention, the pass could essentially be exchanged for a short period of time with parents, or a hug, or if the interfering behavior is maintained by a trip outside of the bedroom, they get access to that at least for a limited period of time at night.
Answering those existential questions that you get, like, when's God's birthday?
Yeah. And one other participant, I believe, in this brief, in the present study, certainly, asked those questions.
Yeah, it said he would come out and ask about mathematics or religion.
Yeah, just really, kind of deep questions and complicated questions, like, why is there God? How do you solve this math problem? And, those questions are certainly appropriate, but they just need to occur at different times.
Yeah.
And I would say that, for that particular participant, he certainly had a history of having these questions answered after the parents bid him goodnight.
Smart on his part.
But I love the simplicity of the bedtime pass.
Me too. And I think that it's very flexible because the pass is essentially an alternative behavior that the child could engage in to get access to the same reinforcers that maintain interfering behavior. For some families, we recommend to start with multiple passes, not just one pass.
Right.
And slowly fade out the number of passes as the child becomes more and more successful.
I made a modification of the bedtime pass like 7 years ago when my now husband was my boyfriend and we had first moved in together, and he would stay up until like 4 a.m, and then I would get up at 5 a.m, and we were going to break up over this because then he would wake me up. And so I gave him a bedtime pass where he'd have to go to bed with me like 3 out of the 7 days of the week, but then he could use this bedtime pass to stay up late. And it really worked, actually. It was kind of hilarious because I read this article.
Did you make him a little card with his name on it?
Yeah.
No, you didn't.
I did.
Laminated the hell out of that thing.
I laminated the hell out of that bedtime pass. I had 3, actually. And it was actually really effective for us. So a modification, Pat Friman, saved my relationship.
The bedtime pass procedure was replicated with an adult.
Right? And it was successful. But it was for the opposite. It was for staying up, not going to bed.
Have you been able to fade those out?
Yes, now I don't care. Now I'm like...
fine, never come to bed.
We have a king-size bed. So I'm like, I get all of it.
You have a baby, too, so the motivation to sleep, it's constantly
so high.
there.
Yeah.
You don't care what time he comes in. If you're asleep, you're asleep.
Yeah, that's pretty funny, though.
That's pretty awesome.
I just remember going into Diana's office and being like, Diana, I've created a bedtime pass. And she was like, no, you didn't. I was like, and Matt's going along with it.
I do. I totally remember that.
Yeah.
Well, I think after all this talk about sleep, I'm getting a little tired. Why don't we take a quick break, and we'll be back right after this.
Hey, ABA Inside Trackers. Are you interested in being a behavior analyst and you're not yet? If so, I really would recommend looking into the Regis College Masters in Science and Applied Behavior Analysis program. Our 2016 pass rates for first-time test takers of the BCBA exam was 90%. We think this is a true testament to our program. In addition, we're going to be starting an on-campus autism center in the summer of 2017. This is going to allow our graduate students on-hands learning right at our college, and you will receive partial tuition remission if you work at the center, which is pretty amazing. We also offer paid clinical placements and graduate assistantships starting in our students' first year, where all of our grad students are working in the field either part-time or full-time. I find you that job. That is part of my job. We also are approved by the BACB to provide intensive practicum, so students will complete 750 hours of an intensive practicum across their time at Regis. All of our faculty are PhD-level BCBAs with strong applied and research backgrounds in ABA, and all have published papers in respected peer-reviewed journals. We ensure small class sizes so that all students receive personalized attention from their professors and advisors, are easily accessible to meet with students. Two more really great things that I want to highlight about the Regis program is that we host an invited lecture series at Regis each year, which involves inviting outside experts in ABA to speak on specialized topics relating to practicing ABA. Last summer, we completed an international service trip to Iceland. This trip enabled students to learn more about providing culturally competent care to diverse populations. Students and alums work with children diagnosed with an autism spectrum disorder and provided parent and teacher trainings for 11 days. This service trip occurs every other year, and the next trip will be in the summer of 2018. And finally, we have a great location. We're just 12 miles from the center of Boston. We currently have rolling admission. We're accepting students until we reach capacity for the fall of 2017. Please check us out at www.regiscollege.edu.
So Sandy, the participants in your study had kind of the standard sleep problems. I would assume, just kind of hearing them. You know, the kid who asked the existential questions, the young boy with autism who had a couple things interfering with his sleep, but one of them being stereotypy in the middle of the night.
Yeah.
Yeah. So maybe we could just leave a quick rundown of like how their treatments shaped up based on the SATT. Which you don't have to do from memory or anything, Sandy. We can contribute to that as well. But I think that if we went through those, then folks at home would get a pretty good idea of what are some common components of a sleep treatment.
You know, speaking from a contingency assessment perspective, I would say, you know, the critical components of a good sleep intervention would include methods to establish the value of sleep around the time a child is bid good night. So, you know, that could certainly take different forms, but one of the, you know, treatment strategies that we typically resort to establish the value of sleep include bedtime fading. So pushing their bedtime forward by a reasonable amount of time and slowly fade it to an earlier and earlier time.
Yeah, like later.
Yeah, I get forward and back like gets me. I like with time when people are like, and I always do it opposite. I'm like, I'm going to push that back. Meaning forward.
I always say I never know if I should turn the heat up or down.
Yeah, that's hard too.
Right?
Yeah.
So, for example, Walter would stay in his room for up to an hour before he fell asleep after he was bid goodnight. So that was what you guys did with him, was push his bedtime forward, so like later, an hour.
Right. So if the bedtime, let's say, is 9 o'clock, then at the beginning of the intervention, rather than instructing the parents to place the child to bed at their regular bedtime, we actually recommend them to push them to a later time, so 10 o'clock, to capitalize on their sleep pressure.
Sleep pressure, that's another thing I was trying to remember. Sleep pressure.
So someone sits on you when you're sleeping?
Yeah.
Get off me.
Make sure that they're really ready to fall asleep, and once they experience success, then we slowly fade it to an earlier and earlier time. And there's obviously a great study by Kathleen Piazza and Fisher published in the Journal of Applied Behavior Analysis, and they used faded bedtime with response cost, I believe, with 2 individuals. So we do recommend different ways to establish the value of sleep. And obviously bedtime fading is not the only way to establish the value of sleep. Things like, exercising prior to the start of their, general kind of routine, or 2 hours before their routine, is another method of establishing the value of sleep. And that could certainly be considered for some families. The other general category of intervention that we consider is occasioning what we call behavioral quietude with reliable and salient stimuli at bedtime. So create healthy sleep dependency by making sure that these stimuli or these events or things that they fall asleep with are consistently available throughout the night, even when they wake up in the middle of the night. And again, part of the common mistakes that parents could make is stay with their kids and put them to bed until they fall asleep. And obviously when the kids sort of naturally wake up during their REM sleep in the middle of the night, and when their parents are absent, they tend to either cry, call out, or get out of bed because that particular sleep dependency is inconsistently available. So, adding healthy sleep dependencies like preferred blanket, or, sometimes we recommend a white noise sound machine that sort of could stay on consistently when the child is expected to sleep, could also be helpful. But again, you kind of have to start at a low magnitude of the sound. Yeah. Takes time to train a person to fall asleep to that noise, I would say. And the other general categories of intervention that we consider are interventions that specifically designed to disrupt the contingencies maintaining sleep interfering behavior. So one of the things we look at is, how do we establish or abolish the value of the reinforcer for sleep interfering behavior prior to and following bidding goodnight. So, how do we make sure that if they are crying and calling out for attention, for example, how do we make attention less valuable after the parents have bid them goodnight? And one of the things that we recommend is, introduce a story time with your kids, right? So have this story time take place before you bid goodnight. And this is an opportunity for you to give attention, in qualitative attention, to your kids. One of the other interventions you can consider, for example, access to stereotopy before bidding goodnight is another procedure you can introduce if that is the putative reinforcer for the interfering behavior. I know it sounds kind of odd, but it's a way to abolish the value of whatever it is that's maintaining sleep interfering behavior. And obviously, the procedures would vary depending on what the reinforcers are.
Right, so I try to look at Facebook on the couch before I go get in the bed so that I don't look at it once I'm in the bed. And then I just go to sleep.
Maybe, right, I would say giving yourself dedicated Facebook time is a good idea, given that it doesn't take place right before you're about to fall asleep. Right? Yes. Because light can certainly affect your melatonin level at night. The fourth, I would say, general category we consider is eliminate any kind of discriminant stimuli for sleep interfering behavior at bedtime. So, for example, if the discriminant stimulus for sleep interfering behavior is the sight of toys, we make sure that we set clear barriers to toys. And one of the things that we do with kids is teach them to kind of clean up and bid their toys goodnight before parents bid them goodnight.
Good. It's like Goodnight Moon, the treatment.
Yeah.
Right. Good night, bear. Good night,
and I would say, finally, one of the, I would say, most challenging and important aspect of the intervention that we have to implement is obviously disrupt the contingency between interfering behavior and its reinforcer. And there are so many different ways to disrupt the contingency, and that, necessitates a comprehensive set of assessment. And I think that's why I think that, this type of kind of sleep contingency assessment could be very helpful when designing sleep interventions. So things like extinction, bedtime pass, time-based visiting, quiet-based visiting could all be ways to disrupt the contingency, but we just sort of have to design it based on what's maintaining the interfering behavior as well as what the parents could reasonably implement with consistency at home.
So between your interview, your baseline data, and kind of thinking about these four main points, that pretty much gives you everything you would need to resolve the majority of sleep problems. And certainly in the article, it allowed you to solve those 3 sleep problems.
Right. And I think that, again, if you look at the specific procedures, they all look different based on each child's sleep problems. But, the logic is the same, essentially. You look at the contingencies for falling asleep and you look at contingencies for sleep interfering behavior. Don't forget about the biological variables that could be at play. And I think that with all of these in mind, we can certainly design a comprehensive and personalized intervention that could be successful for families.
Easy as that. Done and done.
It's just, I would say that designing interventions is fun because it's individualized, right? And during the assessment process, you sort of get the parents' buy-in, and you get the opportunity to kind of interact with them and train them. But again, part of the things that we always have to consider is how to motivate parents to implement these, right? Especially when at the beginning of the intervention, we typically have to provide high amount of support for parents. So yes, I would say that there were certainly nights during which I had to be present as the parents were implementing these treatments and sort of prompt them to visit their kids at certain intervals.
Mm-hmm. Did you have to spend the whole night there?
No, I never had to spend the whole night there, and I don't think neither did my co-authors.
Okay, I always wondered.
We were. I would say there were quite a few nights during which we certainly had to be present initially at the beginning of the night until the child fell asleep, and we were always available to answer questions and to provide support via phone.
In the middle of the night?
No, not in the middle of the night. I don't think none of the parents called us in the middle of the night.
I can imagine be like, Sandy, it's 2:30. My son just woke up crying. What do I do?
Sandy, wake up.
Yeah.
And Sandy's like, hello.
Look at the checklist I gave you. It's outlined in the procedures section.
Hotline.
Yeah, so luckily, none of the parents did that. But if they had, yes, we would have to wake up and essentially answer the call if we're still awake.
Right. Yeah.
Sandy, it mentioned when you were giving support to the parents, you mentioned in the article that someone would go out twice a week because you get the tape to score the tape, and then you'd also give them feedback. So was that like, okay, I watched 20-something hours of your kid sleeping. Here's a tip from a week ago. Don't go in 50 times when they call your name. It's supposed to be extinction. Or was it more general? Let's look at your checklists that we have of what you're supposed to do. Do you remember what that process was like, that feedback was like?
Right. As I recall correctly, we visited pretty frequently at the beginning of the intervention. So yeah, certainly I would say about 3 times a week. And as we were reviewing the sleep diaries, as well as the videos, that certainly, gave us an opportunity to provide feedback on, this is what you could do differently. So I think that during the visit, a quick look at the sleep diary sort of gave us a sense of what was happening for the previous 2 nights. And after kind of taking a look at the videos that day, it also gave us an opportunity to speak with the parents in case they were implementing some aspect of the treatment incorrectly.
Did anyone ever lie in their sleep diaries?
I would say, again, all the data are presented on the ground, so that you kind of get this comparison between the diary and the video data, right? I think that for the most part, the diary video corresponded pretty well with the video data, and I would say that probably happened because we were using both measurement systems simultaneously. So the extent to which parents reported accurately on the diary was to some extent influenced by the fact that we were placing camcorders there on a nightly basis. And they knew that we were watching, and we were also, kind of scoring these video data on a daily basis. Right. So they didn't really have an opportunity to say that did not happen. But I really do have to say that one of the things that I really appreciate about the diary is the open-ended questions that we ask, and just some of the qualitative information that we would not obtain from the video, because placing the video certainly gives us objective information with respect to some of the interfering behavior that could be happening within the bedtime environment. But the parents were instructed to turn on the video, just before bedding goodnight, and turn off the video in the morning. But, there could be other things that were happening prior or earlier during the night that could have set the occasion for some of these problems. And I think that the diary information kind of really helped us to put things in perspective and look at these problems from the parents' perspective, and also understand if they were reporting, sleep problems, or if they were reporting some type of problems that were happening during the night, what exactly were they tacting and what exactly were bothering them. And I think that also helped us to program these interventions more effectively.
So you had to watch 13 hours of videos every day?
Yep. That would actually necessitate a really, really, really long time, as we have a lot of video data. But we did watch on a nightly basis from the time when the child was big at night to when they fell asleep. And yes, for some kids, it really did take hours to score those videos, right? But we certainly did not watch the child sleep for any.
He's still sleeping. Still sleeping.
We used a time sampling strategy. So
smart.
We set their sleep every 30 minutes for the remainder of the night to make sure that they were essentially still sleeping.
Nice. Because I can't even imagine, then it would have taken you, years, right?
Yeah.
A lot of data.
Yeah,
all day to score all night.
Yes. Yeah. And with technological advances, I would say there are always better ways to assess and better ways to, kind of measure this type of sleep problems, or different ways to measure the sleep problems. And I think that, with video technologies are certainly getting better and better, and you can use fast forwarding strategy, obviously. And there are also these software programs that will allow us to detect sound or movement at some point during the night. So if there's some sort of movement that's greater than this particular value, or if the sound level exceeds this particular decibel, then the video will start to kind of activate and record the types of things that were happening in that environment. So that certainly could become helpful in the future. For some families don't really want to use video as their primary measure, we could consider activity monitoring device that's available.
Oh, yeah. My Fitbit will tell me.
Right. Fitbit and other activity monitoring device. And I think that certainly doesn't give us the entire picture, but it'll help us to understand the extent to which they sort of moved around throughout the night. And I think that information is certainly valuable, and for some families it is more socially acceptable. So coupling that with diary might be a more kind of feasible option for some families.
Cool.
So Sandy, was there, of your participants, if you can kind of remember back, what was the treatment that you think was the most challenging to develop, the most challenging to implement? Because certainly some of them read okay, this seems pretty straightforward, and then there were one or two of your participants. I know, reading their treatments, I thought that must have been such a burden for the family, or even just to think of. So did you have one in particular?
Well, first we should say the treatments worked for everyone. We have some nice data.
I would say that there were certainly aspects of the treatments that were challenging, but I think that part of what made it easy, at least from my perspective, is the fact that this treatment was introduced as a package, used in a comprehensive manner. So, for example, if we do tell parents, implement bedtime pass or implement time-based visiting, to some extent, time-based visiting could be associated with increased response effort from the parent's perspective. However, if we combine that with faded bedtime, if sleep pressure is capitalized, if the child's sleepy, then, parents don't really need to implement time-based visiting if their kid's already falling asleep, right? So I think that the comprehensive nature of the treatment package certainly made it easier for the parents to avoid some of the more challenging interventions that could be associated with disrupting the contingency between sleep interfering behavior and its reinforcer.
I thought the situation where the instructions were to go in and redirect stereotypy seemed like that might be challenging.
Yeah.
Because you don't know if that could also there be an attention component to that too.
Right, exactly. And that was what we were considering as we were sort of designing these interventions. And I think that for that particular case, as I recall correctly, it's Andy, we really focused on the faded bedtime component. Okay. So we really focused on the fact that we pushed the bedtime forward and made sure that he had insufficient duration of access to stereotopy prior to the start of the nighttime routine to minimize the opportunity in which the parents would have to implement something like that.
Okay, that makes a lot of sense.
Yeah. And I do really think that, when treatments are introduced as a package like this, we could potentially achieve treatment success more rapidly.
Okay.
So, Diana, you want to go over the results in a little more detail, I think. So did you want to quickly, or Sandy, whoever would like to kind of discuss the graphs or the results that came out of this research? I particularly liked the graph, I forget what figure it was off the top of my head, but where you looked at the individual children's goals, all the different goals they had, and you sort of check-marked the box. Kind of looks like a little beaded bracelet of these are the ones that we met this night, and we met this one that night.
Right.
Well, there were a lot of different graphs here.
What was your favorite graph, Sandy?
I would have to agree with you. My favorite was certainly figure 5, the sleep goals graph, because I feel like you get such a complete picture of each child's sleep, right? With respect to their sleep goals. And it's just a way for us to, sort of profile each child's sleep problems and kind of look at where they are and whether we kind of achieved intervention success in several different areas.
What program did you use to create this graph?
Sigma plot.
Yeah, I knew it.
It's very fancy looking. It's very nice. So some of their goals were decrease the sleep onset to 15 to 30 minutes or less, have fewer than 2 minutes of interfering behavior, have 0 night wakings, and meet 90% of their sleep goal. And then for 2 participants, it was also to fade out additional dependent things. I forgot the word that he used. They were present, like music.
Additional sleep dependencies, like I think that for 2 kids, parents' goals were to eliminate medication, and I think that we were respectful of their decision, and we attempted to eliminate. I think one of the participants was taking melatonin and antihistamine for his sleep problems, and Andy was taking clonidine for his sleep problems, and fortunately we were able to sort of resolve their sleep problems without these medications.
Yeah, which was fantastic.
That's really amazing.
Yeah, and I think that, as I recall correctly, for Lou, we eliminated parental presence. So for this particular participant, his parents stayed with him in his bedroom until he fell asleep, and sometimes, parents reported sort of sleeping on the ground.
Yeah.
On the floor until the child fell asleep, and that certainly, I think, was something that was important for this family.
I would imagine that. I would hate that if I had to sleep on the floor.
Yeah,
because that's like my golden hour.
Yeah. And I also think that it just shows how dedicated parents are to their kids, and they're willing to do anything to help their kids to fall asleep. So,
way to go, them.
Yeah, way to go, parents.
I know.
And when you were done with the study, you did the social validity. You had a social validity questionnaire, and your average across the families was real high. I think it was almost perfect scores.
Luckily, yeah. We're very happy because when we administered the social validity questionnaire, we weren't sure. We're asking a lot of different types of questions. Did they find a consultation to be helpful? Did they find the treatment to be effective from their perspective, not from our perspective? And was the assessment acceptable to them? And this was essentially our first time implementing this or administering this social acceptability questionnaire. So getting high ratings from parents was certainly, I think, a bonus for us.
Did you make sure to give them the questionnaire after you knew they'd reported, like, I've had 3 nights of I've slept all night, I'm so rested, and then you gave them the questionnaire, you're like, oh great, now that you're well rested, here, fill this out, please.
No, as soon as the study ended, we administered a questionnaire. That's hilarious.
Very responsible of you.
Have you followed up on these participants at all? I don't know if you can, but are they still sleeping?
They never woke up. It was that good a treatment.
Yeah, I don't know. I think that, we included follow-up data for one of the participants, but I don't recall. I don't know where they are right now. I don't know if,
Where are they now?
My hope is that they're still sleeping very well right now.
Hopefully they're in bed right now because it's 10:30
Yeah,
here,
hopefully they're in bed. Hopefully they're sleeping. Hopefully they have acquired important sleep skills. And I think that, that's certainly an important aspect to look at.
I bet they are. I hope their parents are asleep too.
So
and I hope their siblings are sleeping.
Yes, everyone should be asleep in these households. Well, Sandy, there's a section that we do on the show we call Dissemination Station, which starts a little something like this.
That's my sick one.
And that's sort of our signal to talk about the kind of the bigger picture of where sleep research is. Are you actively pursuing any research at the moment? Are there areas you think should be pursued? And to be honest, is this it? Do we have everything we need to know to put together our kind of model of these are the questions to ask when someone says, my kid's not sleeping, and you can handle any problem the world will throw at you?
Certainly not. Yeah, there are so many studies to be conducted in the future. There are so many questions to be explored, and we certainly have more studies in the work. And one of the studies that we were working on were essentially focused on designing these types of individualized and comprehensive interventions for different children's sleep problems, but also compare different types of strategies for sleep interfering behaviors, because we don't really know the relative efficacy of different types of treatments for interfering behaviors as well as their social acceptability. So believe it or not, we actually had families who are willing to implement extinction, time-based visiting, and bedtime pass, and sort of randomly alternated among these strategies across various nights. So they implemented extinction on some nights, bedtime pass on other nights, and time-based visiting on some nights. And at the end of the treatment comparison, once their children's sleep problems were resolved, we, presented stimuli that were correlated with these 3 treatment options to the kids. So they had an opportunity to choose the treatment that they sort of most preferred, and whatever stimulus, and in this case colored card, that was correlated with treatment that they selected, parents then implemented for that particular night.
Oh my God, I love that.
That gave us an opportunity to look at consumer preference, children's preference for these strategies, and we also sort of asked parents which strategy that they most preferred. So this type of kind of comparative studies are certainly important. And I also think that, studies evaluating the extent to which behavioral intervention is efficacious either with or without pharmacological intervention would also be important to look at. So many of the children who are referred to us when they experience sleep problems, they are, being recommended different types of pharmacological intervention. So can we actually treat sleep problems satisfactorily with behavioral interventions without pharmacological intervention? And what is the efficacy, or are there any conditions in which pharmacological intervention may be necessary? We just don't know at this point. And, looking at different ways to better measure sleep would certainly be an important question to investigate, because this line of research is certainly very time consuming because of the response effort associated with data collection. So definitely looking at more efficient ways to measure sleep, looking at measurement systems that are reliable, valid, and sensitive to the effect of independent variables would help us to do more sleep research in the future. And finally, I think that again, treatment compliance research in this area is really important. What can we do to motivate parents to implement treatment more effectively with consistency, and kind of getting a really close look at their treatment integrity would be important.
So for the average practitioner, if they're meeting with parents and parents say, "Oh, sleep is the biggest problem. I need help with this," would you recommend that average BCBA sort of look into the research and attempt to follow some of these procedures? Or is it really the sort of thing that unless you are set up to handle the amount of kind of extra time commitment that goes into helping a family resolve a child's sleep problems, that maybe they find someone who's more of an expert in it or who's better set up to handle it? Or what do you think?
I think that, certainly BCBAs could adopt this type of assessment approach, and when they're designing interventions for different kids who experience sleep problems. And I think that as long as you are taking the contingencies, maintaining falling asleep, and contingencies maintaining sleep interfering behavior into consideration when designing your treatment, you're more likely to, at least in our opinion, program a more successful intervention for sleep problems like delayed sleep onset, problem behavior at bedtime, night waking, as well as early awakening.
Hey everyone, Rob here one more time with our second secret code word, and that word is Sandman. Sandman, all one word, like the mythical creature that puts you to sleep. Or maybe it's like a horror movie thing that rips your eyes out or something creepy. Ugh, anyway, Sandman. Yikes. Back to the show.
I've been reviewing this anecdote in my mind here, and Rob and I have a sleep intervention that we've been doing with our kids sort of without realizing it, which is that ever since they've been really young, we have placed a relatively friendly but still monstrous looking stuffed animal monster under their bed.
He looks more like a Jay Leno with horns.
Yeah, but he's a monster type thing. And whenever they say, I am worried that I have a monster under my bed, we say, yeah, you do have a monster under your bed. He lives there. He's always there, but he's a friendly monster, and you can only have one monster under your bed, so he's your monster, and he will keep away any scarier monsters.
They noticed we moved him because he's under the baby's bed now.
Yeah.
So the older two boys realized he wasn't under the bed anymore.
You guys need two monsters.
Yeah, we might have to get another one. But it worked like a charm. They're like, oh, okay, that's fine then. So, I don't know. Maybe we gave them adequate attention related to it prior to bedtime. Is what's really going on there.
It's like a Princess and the Pea kind of scenario.
Yeah, right.
It's my most favorite fairy tale.
Is it really?
Yeah.
Why?
It's because you're a delicate flower, Jackie.
I am delicate. I can feel everything.
I just assumed she would topple over. There's so many mattresses, she would sort of just topple over in the middle of the night.
That would be me. All right.
Well, Sandy, thanks so much for calling in and being on the show. This is such a fascinating topic. I think it's one that, again, reading your article is one of those like, oh, yeah, no, that totally makes sense. But that without it, sleep just seemed like this strange foreign beast that there was no way to describe to anyone in a way that made sense. So thank you so much for doing this research. Thanks so much for talking about it. And thanks so much for continuing to explore this realm.
Thank you so much for inviting me.
Yeah, it was a pleasure.
Anytime.
I'm going to sleep a full night's sleep tonight.
I know. I'm ready.
This riveting conversation.
I know all the things I do wrong now from sleep research, so I can stop doing them today.
Tonight's the night.
So everyone at home, thank you so much for listening to ABA Inside Track. We're a podcast that comes out weekly on Apple Podcasts, Stitcher, Google Play, anywhere you can get your podcasts. You can find us online on Twitter and Facebook as ABA Inside Track and at abainsidetrack.com. You can also find us on YouTube, and if you want to email us with suggestions for topics or questions, you can do that at abainsidetrack@gmail.com. Also, don't forget, ABA Inside Track is a continuing education provider source. So go back and listen to you've already listened to the episode, so you've heard all our secret code words, and you can find instructions as to how to apply for CEs on our website. Or you can just email us as well. Well, again, Diana and Jackie, thanks so much for being here.
Thanks, Rob.
You bet.
Sandy, extra special thanks for you for being here as well.
Thank you.
Big hug, Sandy. Big hug.
Yeah.
Everybody else, we'll be back next week with our preview episodes. You can hear what we'll be talking about next. But until then, keep responding. Bye.
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 Go to bed.